Welcome to Knowing Your Way, a Princess Margaret Ovarian Cancer podcast. I'm Dr. Alicia Sarabia, and I've been a patient of the Princess Margaret Ovarian Tumors Program since 2015, when I was originally diagnosed with ovarian cancer. Today's episode of Knowing Your Way will focus on genetic testing in the setting of ovarian cancer. I think this has got to be one of the most exciting developments in cancer research, as it's been able to help so many people who either have ovarian cancer or who are related to someone that has ovarian cancer. Here with me today, I have two very special guests. I have Halley Sauve, a 36-year-old woman who was able to put in place some preventative measures to reduce her risk of ovarian and other cancers after she tested positive for the mutation affecting the BRCA1 gene. And I also have Dr. Jeanna McCuaig with us. Jeanna is a counselor, a genetics counselor at the Princess Margaret Cancer Center. Thanks so much for being with me today.
Thank you.
Jeanna, why don't you start off by telling us what is meant by hereditary cancer and what role genetics plays in hereditary cancers?
Sure. So there's different ways that cancers can develop, and a small portion are what we call hereditary, meaning that someone has inherited an increased risk to develop cancer in their lifetime. And that has to do with our genetic information that we're inheriting from our parents. On the whole, I would say 5 to 10% of cancers are happening because of an inherited risk that somebody has. But with specific types of cancers, we can see the proportion being higher. So in ovarian cancer, the likelihood that someone's ovarian cancer is hereditary depends a little bit on the type of ovarian cancer that they have, but is about 20%. So 20% of ovarian cancers can be caused by an inherited risk, meaning the other 80% are happening more because of a chance events that are occurring throughout someone's lifetime. And so with hereditary, we start talking about our genetic information or our genes. And essentially our genes are the instructions that we inherit from our parents that tell our bodies how to grow and develop. And so the same way we have genes that tell us what we're going to look like, how tall we're going to be, what color eyes we're going to have, we also have genes that their job in the body is to protect us against getting specific types of cancers. And so if we're born with a particular change that we call a mutation, or the technical term is a pathogenic variant, in a gene that's meant to protect us against getting cancer, it means that gene is not working the way it should. And the way I like to think about it is that we have less protection against cancer. And so our chance of getting specific cancers in our lifetime can be higher. And so that's what we mean by a hereditary risk versus someone who's born with 2 working copies of those cancer protection genes, who may acquire genetic damage throughout their lifetime and develop a cancer more by chance.
Okay. And you referred to cancer due to chance events, and that would be the majority of cancers. How does genetics relate to that type of cancer?
So within a tumor or a cancer, we often think about cancers as being a disease of our genetic information. And so basically what happens is, as we're living our lives, we're exposed to different things, or chance events can happen to our bodies that cause genetic damage throughout our lifetime. And if we have a gene, for example, that's meant to be, again, protecting us against getting a cancer by controlling how quickly our cells grow and divide, if we're acquiring genetic damage in our lifetime, we would still see that genetic damage within the cells of a cancer. It's just not something we were born with, and so not something we would pick up, say, through a blood test.
Okay, so would an example be a skin cancer? If a person was exposed to high levels of sunlight and got burns throughout their childhood, is it possible that that would then make for genetic damage, I think as you referred it to, and then that would increase the risk of them acquiring a cancer that's not necessarily hereditary?
Yeah, so skin cancer is a good example, especially when we think about the basal cell cancers that we can see that are more related to sun exposures. People often think about lung cancer as an example, and smoking being something that can increase risks of lung cancer. There's always exceptions, right? Where sometimes skin cancers can be hereditary, or sometimes lung cancers can be hereditary. But yeah, that's really what we're talking about.
Okay, great. And so then how does a person go about finding out whether or not they may have inherited that mutation from their parents?
Yeah, so oftentimes people are getting referred to genetics. So someone would see somebody like me. We have a detailed conversation about their personal history and their family history. And we look at the family history, and we're looking really not just at, whether people in the family have had cancer or not, but looking at what types of cancers people have had, how old people have been, how closely related they are. Because, for example, we can see a genetic link between breast and ovarian cancer, but we don't see a link between breast cancer and cervical cancer, right? So even though ovarian and cervical cancers are both gynecological cancers, the way they happen is very different. And so, based on where someone is living and different health guidelines, there are specific criteria where, say, in our publicly funded healthcare system, genetic testing would be available to somebody. And so based on an assessment of the family history, if that's something that we can organize, we talk to people about their options, what genetic testing is, what it can and cannot tell them in terms of information about hereditary cancer risk. And if people are interested in knowing that information, then it's typically blood work that's arranged through specialized labs. So there are specific labs that do the testing. And even though it's a blood test, it still is complicated for the labs to look at the genetic information. So it takes a couple of months for those results to come back.
Right. So if you had someone come to your clinic and they were concerned about having inherited a mutation that increases the risk of ovarian cancer, you would go through the family history and the details around that, and then determine if in fact the concern was supported by that history. And then you may offer the option of the testing to that person, and it would be a matter of a blood test in that case,
yeah,
which could be arranged through one of the labs.
Yeah, exactly.
Okay, thank you. And Halley, why don't you chime in and tell us how it is that you came about to having the genetic test done?
Yeah, so I think in my case, it's definitely a bit more unique. I lost my mother to ovarian cancer. So that what kind of brought about wanting to be tested, or brought about the questions of wanting to be tested. And originally I'd gone through, so I'm here in Ottawa. I'd originally gone through our genetic testing lab here, and I didn't actually meet the qualifications set forth for genetic testing. And I believe since they've actually been changed for the better, for sure, because in my case, I wasn't eligible for testing. And then conveniently enough, I'd been directed to the Prevent Ovarian Cancer program out of Princess Margaret, who at the time was running or doing a study on participants who'd lost a first-degree relative to ovarian cancer.
Okay.
So through them, I went through a series of genetic testing, and it was determined that I have a mutation in my BRCA1 gene. And then it goes a little further in that it wasn't, so they tested it, after it was determined that I had the BRCA1 gene, I granted permission for them to test a sample of one of my mother's tumors, which was kept here at one of the Ottawa hospitals. And it was determined that she also had a BRCA1 mutation. And I don't want to confuse things, but my variant and her variant, so what those little differences are in that gene were different. So the most likely of circumstances is that I inherited my gene mutation from my father, and then she would have passed her healthy gene on to me while she still did have that mutation as well.
Okay, wow,
so both of my parents in that case had the BRCA1 gene mutation. We do have this on my father's side. There's more history of breast cancer and pancreatic cancer, and then on my mother's side, there's the ovarian cancer.
Okay.
But it was really easy, like they said. So it was blood testing. I mean, there was a bunch of testing that went with it, but it came down to I had a sample of my blood taken, and it did take a few months to get it back. I remember I think it was 2017, I got my results. So yeah, it took a few months, but besides that, it was easy. I was put in touch with counselors. Again, I got retested here in Ottawa to confirm that the variant was there. And it was a bit quicker because they knew what they knew what variant they were looking for
Right.
in my sample. And yeah, so that's that's how I found out.
All right, thank you. We'll talk about what you did with those results a little
Yeah.
bit in the episode. I'm sorry to hear about your mother. And I think if there's any silver lining to this, that at least in my situation, I was able to tell family members, about my positive BRCA2 mutation status. And I'd like to believe that that's helping members of my family as it did you. And
Yes, definitely.
Yeah. Jeanna, so it is kind of complicated. There are a number of different genetic mutations that increase the risk of ovarian and other cancers in the ovarian cancer setting, right? Can you, at a high level, not too complicated, tell us what is entailed in the testing in terms of what we're looking for?
Sure. Yeah, and that's changed over time as well. So 5 years ago, let's say, if someone had a genetic test done, we were really focusing on two specific genes, so BRCA1 and BRCA2. And those really stand for BR is for breast, CA for cancer. So breast cancer gene number 1 was found first. We're not that original in our naming, so BRCA2 was found second. And people often think BRCA1 is a breast cancer gene, BRCA2 is an ovarian cancer gene, but they both actually relate to increased risk of breast and ovarian cancer. As our technology has gotten better and our understanding of hereditary cancer risk has gotten better, there's been more genes we've learned about. And so oftentimes when someone is having a genetic test now, we'll do what's called a panel. Which means we're looking at many genes all at the same time. And in Ontario, we typically do a panel of about 20 genes that could relate to increased risks of breast, ovarian, and prostate cancers. And depending on the gene, the specific cancer risks are a little bit different. And in some instances, there can be links with other types of cancers above breast and ovarian cancer. But it's hard for us to go through too much information up front when we're talking about 20 different genes in terms of percentages, right? So at a high level, we're just looking at genes that would be related to breast and ovarian cancer. And then if we see something, we can give people more tailored information about their specific risks and then also what we do to manage those risks.
Okay. I guess, well, why don't we continue the conversation in that vein? The person that hasn't been diagnosed with cancer but has gone through the genetic testing. And then we'll get back to people like me, for example, that have the cancer, get the testing, and then have some actions take place. So you said that you would counsel the patient that's been positive for a mutation, depending on what the mutation is and I guess what sex the patient is and other things. So can you give us an example of what you might discuss with that patient?
Yeah, and so if we kind of stick to, say, BRCA1 as our example, we know with BRCA1, the biggest cancer risks are for females to develop breast cancer and also ovarian cancer. And so we talk about those numbers, but also put them into context. So the chance for someone, a female who has a BRCA1 mutation, to get a breast cancer in her lifetime is between 40 and 70%. Yeah. Now, those are big numbers to wrap your head around, right? But I like to focus on the fact that it's not 70% chance tomorrow that you get a breast cancer. It's adding up, 1, 2, 3% per year over a woman's whole lifetime. And so we can tailor that based on how old they are to say, in the next 10 years, this is what your breast cancer looks like. And the older someone is, the more risk that's behind them. So someone who is 60, who learns about a BRCA1 mutation, her breast cancer risk is not going to be as high as what it was when she was 20. So that's one thing we talk about with ovarian cancer. With a BRCA1 mutation or pathogenic variant, the chance to get an ovarian cancer is about 20 to 40%. in a woman's lifetime. And again, those risks start to happen a little bit older. And so we put that into context for someone, if they're in their 20s, the risk is not high at that point, but it's more as they're getting towards late 30s, 40s that we start being concerned. When we talk about different options for them as well, in terms of enhanced breast cancer screening, doing things like breast MRIs and mammograms every year. Some women think about surgeries to remove their breast tissue as a way of reducing risk. With ovarian cancer, we unfortunately don't have good screening options. And so we focus a lot more on ways of reducing the risk with surgery once people have completed their families or are getting towards kind of late 30s or 40s. And with males, we talk about prostate cancer risk. And so with BRCA1, the risk is maybe 20 to 30% for a man to get a prostate cancer. And so screening is important for them starting around age 40, doing digital rectal exams and PSA blood testing.
Okay.
And we also talk about implications for their family members, obviously.
Okay. So if a male does not have that increased risk by way of the genetic testing, when does screening for prostate cancer typically start?
I mean, typically at age 50, unless there's family history. I also know that screening for prostate cancer is a little bit controversial. And so some family doctors, think it's helpful, and some family doctors don't. And so normally I would suggest that that's something they should discuss with their primary healthcare provider.
Okay. But for folks that have, for example, the BRCA1 or 2 gene mutation, then for sure you'd start earlier rather than later as a male. Okay.
Yeah, exactly. And the risk for a male is actually higher if they have a BRCA2 mutation.
Right.
So it's important that they do the screening. It also can impact if there's a prostate cancer that's seen, what the plan would be in terms of any kind of treatments and whether they do kind of watching and waiting or active treatment. And so it's helpful for the doctors to know.
Yeah. My dad passed away of prostate cancer.
I'm sorry to hear that.
And as I mentioned, I have the mutation for the BRCA2 gene. And, as time went on, then there were other family members that developed different cancers. But my father was the only family member that had prostate cancer that I know of. Yeah. So, okay. So we've talked about enhanced screening. Should a person be positive for the gene? I guess notifying. Well, why don't we talk about Halley's experience? Because she certainly undertook a pretty major procedure to help her reduce her risk of breast cancer.
Yeah, so with my experience, it I guess more on, so definitely notifying family was a big thing too. In my case, I had to notify both sides. Not too many family members have participated in testing so far. I know more plan to. I have a younger brother, and I think he's kind of holding off for a little bit. But it's good information to have. So I'm given a letter. I can hand out details, what studies were done, what variants to look for in both genes, and I can hand it out now to both sides of the family. And it just kind of helps narrow things down. Now, what finding out for me meant was that I was eligible for things I wouldn't have been before. So in my case, about a year after I found out, so back in 2018, I started prophylactic surgeries on the breast. I had the option to get a double mastectomy with reconstruction here from teams in Ottawa. And that's what I did, I think at 32. I went through it with those surgeries. For me, like, it's a very personal choice for everyone. Just because you have this mutation doesn't mean you have to go ahead and do anything. As stated, at least with breast, there's a lot of screening tools in place. For me, I just didn't like that kind of ticking time bomb kind of feeling with it. And then in the future, I'm 36 now. Going ahead with ovarian surgeries means I'll be put into surgical menopause. And at where I am right now, I'm not ready for that. But it's definitely something that's on my mind. Here in Ottawa, I was put in touch with a great group. There's a support group here in Ottawa, and I think there's a lot of chapters kind of all throughout Canada and in the world in general for people with genetic mutations, not specifically BRCA1, but that seems to be the focus. So it's the BRCA chat group. And then it's a women's support group for women who have it. Going to that definitely helped me make my choices to go ahead with certain surgeries. It was great to see what results people had. And it was really like a great eye opener, but a great support system as well.
Yeah, so sorry, can you tell us again what the name of the support group is?
So here it's since I've been participating since 2017. After I found out I had the mutation, I started attending it. It's a monthly support group, and it's BRCA, so like BRCA support group, but you can apply. There's more than one genetic mutation that can affect breast and ovarian cancer. So it's really open to all,
right?
Or at least or for women, it's a women's support group.
An online group, but
so we actually meet in person. So the Canadian Cancer Society, they have a survivorship center here in Ottawa, and I believe they probably have other locations all over Canada as well. That we meet in person. So through COVID, it was a bit of a challenge. We did meet online through Zoom meetings like this, and now we're meeting in person again. So we've had 2 meetings in person. So we'll see how it goes, because it is a cancer survivorship center. We do have to be careful going in and out of there.
right.
Yeah, but yeah, so we meet monthly right now, and fingers crossed we get to continue to meet in person, because I found it really helpful. Just kind of getting to see people in different stages of prophylactic surgeries, just talking about your different options, because you're not limited to one option. Like I think it's a whole other, like you could probably do a whole podcast on what options are available to people. For me, I chose to go ahead with the double mastectomy with reconstruction.
Right.
But yeah, it was definitely very helpful in finding that.
Sorry to interrupt you. Yeah, we will be having an episode that will deal with prophylactic mastectomy and other options for women that are found to be positive for these genetic mutations. And it's good to hear that these support groups are out there. I've heard others talk about similar support groups, and it must be such a big decision for anybody to make. I can't imagine anybody would take that whole issue very lightly. I considered it myself not that long ago, maybe 3 years ago or so. And, I considered what the risks were. And at that time, it didn't seem like it's something that I wanted to go through, but I did stick with the yearly MRI and mammograms that were available to me. Correct me if I'm wrong, Jeanna, but if you're positive for the BRCA1 or 2 gene, then you are automatically, you become part of the high risk breast screening program for Ontario at least. Yep. So then you automatically get a notice, Alicia Sarabia, your MRI and mammograms are scheduled for this day. And it's just an automatic thing. It's a great thing actually to have in place for us.
Yeah, it's great, because then people's doctors don't have to remember to order it every year. And that program is for people who have a BRCA1 mutation who are between ages 30 and 69. So there are kind of these flanking ages where there are guidelines depending on the gene where that breast screening might need to start a bit earlier, say at age 25. And so we still refer people to a breast specialist to do clinical exams. And then if people are outside of that 30 to 69 age range, they can have a discussion about the role of doing the screening either younger or as we're getting older. I mean, as we're getting older, our risk tapers off, and also our breast density tends to be lower. And so the added benefit of the MRI is very individualized based on someone's personal history. As well as, what ages of the cancers may have happened in their family and what their breast density and things are like. So yeah, the screening program is set up in Ontario for those age ranges, and outside of those age ranges, it's more of a discussion with the breast specialist.
Okay. I just wanted to circle back to discussions with family members. If you yourself are found to be positive, I think it's a really good thing that that's available, but it may also be a very difficult thing to discuss with family members. And I think it's a great thing that you, Halley, had information provided to you that you could then provide to your family members. But it is difficult, right, to talk about these things. I didn't have so much of an issue talking to my siblings or to my cousins who are all about my age. But for me, the discussion with my children was really hard. And, you know, I even felt guilt, for example, that I was positive and that there was a 50% chance, I guess we should say that, of one of them inheriting the genetic mutation. That was tough. I mean, it was really good once it was done, but getting there was really difficult for me. Halley, what was your experience like? You mentioned that a number of relatives they've chosen not to get the testing yet anyways.
Yeah.
Yeah.
So, I mean, and I find this with a lot of people too, like you'll end up with people on both sides, your family that do want to get tested and some that don't. Everyone has their personal reasons. For some people, it might be too heavy to carry. Circling back to the children's side of things, I'm like you, I have 2 young children. And it was definitely one of the hardest parts about finding out is the possibility that I could have passed this gene on to them. But I don't think my parents would have wanted to undo me, and I wouldn't have wanted to undo my children. And I think, I mean, especially the opportunity I was given with the Prevent Ovarian Cancer program and finding out, it just allows me to have opportunities I wouldn't have been allowed to, because I'm sure there's people out there living with this gene mutation who just don't know it. Who won't have the opportunity to be tested or even the knowledge to know that you can be tested. I personally feel, at least for myself, it's better knowing than not. It afforded me a lot of opportunities in how I can kind of take charge on my health. And that's definitely not for everyone. But it'll also give my children, if they choose to, when they come of age. So I don't believe you can be tested before the age of 18 for the mutation. And you can correct me if I'm wrong, but I believe you can't be tested before 18. I'll definitely give my children the option, but I personally feel it's definitely a personal choice. It's nothing I'll choose to force on either of them, but I think it's good to know and have options for sure.
It speaks to the importance of having good counseling with somebody such as Jeanna, sitting down, taking the time, explaining what it all means. You know, it takes I think a real high degree of sensitivity to the issue and the circumstances. And I'm grateful that both my kids had the counseling in place there, you know, because it couldn't have been any better for them to then make a decision one way or the other. Jeanna, do you want to comment on that?
Yeah, I mean, I think you both put it quite well, that it's an individualized experience for everybody, right? And the whole reason why we have conversations about what genetic testing can and cannot tell you is that sometimes people hear that and they decide, you know what, I don't want to know, or maybe I don't want to know right now, right? So Halley brought up a good point of we don't test people for adult onset conditions when they're minors, right? So somebody at 14, the benefit of knowing, and definitely some 14-year-olds are more mature than others, I appreciate that, but the benefit of knowing at that point and then not doing any screening for another 11 plus years, like really is that, are we doing a disservice to that person? Versus some people might have anxiety with the not knowing, right? And just wanting to know one way or the other. So I definitely can see, and I've heard from people different experiences, right? There's also instances where someone has assumed they have this risk their whole life, and maybe we do testing and it comes back negative, which we always assume is great news for somebody, but it really impacts their identity and the fact that they were assuming that this is something that's happened, and maybe other people in their family have this risk and now they feel they can't really relate anymore. And so there's definitely a lot of family dynamics that make things complicated.
Right.
Yeah, and it's hard because I appreciate we're kind of asking people to be genetic counselors for their entire family. And so we try to give information to help with that in terms of these letters to help share information. But obviously family members are going to have questions, and it can be quite burdensome for someone to share information with their entire family. But I mean, it's important because as much as we're sharing news that might not be, you know, so great, we're also, as Halley's saying, giving people opportunities to learn about this information so that they can do things to better their own health and have these opportunities that might otherwise be unavailable to them.
Right. Yeah. Okay. Thanks for summarizing that. Let's just shift a little bit and turn to the people that have been identified as having ovarian cancer. Why should apart from increased screening, let's say if I've got ovarian, I've got increased screening for breast, why else is it of benefit to have the testing done? Why don't you start by helping us with that?
Sure, yeah, and I think this is becoming important for ovarian cancer as well as other cancers, that we're learning more and more about the biology of different cancers and the differences between cancers that are related to specific gene mutations versus those that are not related. And so there can be targeted therapies that might be helpful for somebody. And so having their oncologist know information about whether there's an inherited risk might determine any particular therapies that would be of more benefit to them. I mean, it's not the only thing. There are lots of things that go into those decisions. But nowadays, there are particular medications called PARP inhibitors, which we know have better outcomes for women with ovarian cancer who have a BRCA1 or BRCA2 mutation that's related to their cancer. And so it can really be helpful in terms of determining their treatments.
Okay. And you don't have to answer this question if you're unsure of the answer, but we're focusing a lot on the BRCA1 and 2 gene mutations, but as you mentioned, the panel tests for 20 different types of mutations. Is the PARP inhibitor therapy being extended to other women with a genetic mutation other than BRCA1 or 2?
Yeah, and so that I always kind of defer those decisions on particular treatment to the oncology team. I think a lot of the studies looking at PARP inhibitors first focused on BRCA1 and BRCA2 because we have a good understanding of that mechanism. But there are other genes on the panel that follow a similar mechanism. And so there's an idea there that PARP inhibitors could also be helpful. And I believe that different other PARP inhibitors have been approved for use in people who do not have a BRCA mutation. So definitely they can be used for other individuals, but I'm not going to comment on the specifics of which gene because I just don't want to give people false information.
Yeah. Okay, thank you. We do have an episode coming up on what we call maintenance treatment, where we'll be having an oncologist give us further information on treatment options for which the genetic testing results are very relevant. Yeah. So stay tuned, listeners, for that information. I also wanted you to please comment on testing of tissue that is removed at the time of the original surgery or maybe biopsy from the patient, in addition to blood testing, and why that's important.
Yeah, and so we call that kind of tumor testing or tumor genetic testing, and that often is being done as an automatic process as part of someone's pathology review. So when someone has a surgery or a biopsy, a sample of the tissue is going to the lab to get a better idea of the biology of their particular cancer and really to confirm that there is a malignancy that's there, right? And so if it's an ovarian cancer that's identified, a sample of that tissue would go to the genetic testing lab. Mostly they're focusing on BRCA1 and BRCA2 when we test the tumor tissue. And that's to get a better idea of the biology of the cancer and whether someone would benefit from one of these PARP inhibitors. Now, in the tumor tissue, remember when we were talking about genetics earlier, we were saying that some gene mutations can be acquired in someone's lifetime versus some can be inherited and it's something that they were born with. So when we look in the tumor tissue, we are seeing genetic mutations that exist, but we cannot tell from the tumor tissue alone whether that was something that was acquired in someone's lifetime and doesn't have any impact for additional cancer risks for them or their family members, or was this something that they were born with and so would be in the other cells of their body, and so might relate to other cancer risks and could have been passed on to family members. And so the tumor testing tells us about the biology of the cancer. We'd like to do a blood test in addition to get a better idea of, is there an inherited risk? And then also with the blood test, we are typically looking at more genes than what is tested in the tumor. So it's two completely different questions that are being answered through a tumor genetic test and a blood genetic test, but I would say they are both equally important in terms of assessing someone's treatment when an ovarian cancer has happened.
Okay, good. And I think this is something in my reading that's being emphasized more and more because of the treatment implications as well. Okay.
Absolutely. So if someone has a negative genetic blood test,
yeah,
they still should have a tumor test because there could be something in the tumor that's not inherited that would still impact their treatment.
Right, right.
I think that's what we're learning more now.
Right. Okay. I wanted to swing back to another issue that I probably should have asked earlier to have a nice flow of conversation, but it's really important too. And that is, if patients need to pay for the testing to be done, and if they should be concerned about getting testing done with regards to their health insurance.
Right.
Yeah. So Halley, for example, she underwent testing as a result of being part of this study that you were part of out of Princess Margaret. But there are others that aren't part of a study. A, do they have to pay? And B, should they be concerned about any impact on their insurance packages?
Yeah, I mean, and in terms of paying for testing, again, it depends where someone is living, right? Different provinces in Canada have different criteria for where they will fund genetic testing. And so seeing someone in genetics, that's kind of the first thing we look at is, do you meet these criteria where OHIP or what other provincial health plan would fund the testing? There are some people who we see who, might have a concern, but they really have no relevant or not strong enough kind of personal or family history where OHIP is not going to pay for the testing. There are options. There are a number of labs where people can access testing. Sometimes they need a referral from a doctor. Sometimes people can kind of enroll themselves. And the cost of the testing varies depending on where people are having that testing done.
Okay.
If someone has testing, whether it's that they've paid for it themselves or that it's done through OHIP, there is legislation in Canada called the Genetic Non-Discrimination Act that does protect people against discrimination based on genetic testing results for things like insurance. And so insurers cannot ask about genetic testing results. They cannot ask people to have a genetic test in order to assess their eligibility. It's important for people to recognize, though, that Genetic Non-Discrimination Act does not cover someone's personal or family history. So if someone's personal or family history was strong enough to warrant genetic testing, it's possible that that could still be information that insurers are using. But the genetic testing is not something they are allowed to ask about. And so if that's something that's coming up in someone's insurance questionnaires, I would push back on that.
Okay, thanks for clarifying that. Let's see. We could also, all of this is very complicated and it's pretty sensitive subject matter to talk about. I know of measures that women who are planning families can take to in the context of being positive for one of these genetic mutations. I think I'm sounding a little bit obtuse, but Jeanna, as the expert, do you want to, at a high level again, discuss what women are thinking about sometimes in these situations?
Yeah, absolutely. And like you say, it's not something that every couple is interested in knowing about, but in particular, when we see people who have not completed their families yet, we talk about options for either testing during a pregnancy or testing before a pregnancy to know whether one of these gene mutations have been passed along. So we've been talking about this 50% risk, but we haven't really explained why that is. And so I think that's a good place to start as well. If somebody has a hereditary cancer risk, whether it's in the BRCA1 gene or another one of these genes we're talking about, people have 2 copies of each of those genes, one they got from each parent. And when we have a hereditary cancer risk, we have a mutation in one copy, but the other copy of that gene is working just fine. And so when we go to have children, it's completely random. We have no control over this, but either we pass on the copy of the gene that's working or the one that has this mutation and it's not working. And that's where we get that 50-50 chance. And so for couples, some couples, and sometimes we have to go through fertility treatments just in general as a couple, or because we've had a breast cancer and we're freezing eggs in advance of any of our treatments, right? So particularly if people are going through IVF anyways, or they just want to know that information, there are ways of doing what we call pre-implantation genetic testing, where a couple would go through in vitro fertilization. There's an embryo that's created, and at a certain stage in the development of that embryo, a single cell is taken that's not going to impact the embryo, but we can send that cell to a lab to do testing. And it's really specialized tests for the couple themselves to know that embryo, would that embryo have the mutation or not? And then we can select those embryos that do not have the mutation for a transfer. Now there's cost to that, right? And so not every couple is interested, because even if there is funding or support for the IVF portion of that, typically the testing of the embryo is not something that's covered. And so those are things I always say that people should talk to the fertility specialist about to get a better idea of cost. The other thing is there's no guarantee of a successful transfer, right? So it definitely can be helpful information, but it's not an absolute that this is going to be kind of a slam dunk solution for people. Also, some couples may choose or just become pregnant naturally. And so there are options for testing during a pregnancy to know whether a hereditary risk was passed along or not. And so there are different options depending on how long, kind of where a woman is at in terms of her pregnancy. And so there's something called chorionic villus sampling, which happens earlier in pregnancy, usually between 11 and 14 weeks, where they're taking a small sample of the placenta, either kind of going through the cervix or going through the abdomen, depending on where the placenta lies. And the cells that make up the placenta are the same genetic information that would make up the baby. And so we're able to test those cells to know, did the mutation get passed or not? A little bit later in pregnancy, people may be more familiar with an amniocentesis, where there's a needle that goes through the belly, usually around 15 and a half weeks or any time after that, where we're taking a sample of the fluid that surrounds the baby, which would also include some skin cells from the baby. And we're looking at the genetic information from that to know, again, did this mutation get passed along or not? And then couples can make a decision about how to manage the pregnancy, right? And so some couples just want to know the information and would continue the pregnancy. Some couples may decide to stop a pregnancy, and that's also a very individualized decision.
Yeah, for sure. All right, so just to summarize at a high level, either before pregnancy occurs by way of IVF or in vitro fertilization with the super specialized genetic testing of the embryo. And the embryo is when the male sperm and the egg come together to form what will eventually develop into a baby. So the embryo is when the sperm and the ovum come together, and the genetic information from each of the parents comes together in order for that to happen. And then during pregnancy, there are also options for couples who are interested in having genetic testing of the embryo, the developing embryo. Great.
Exactly. Yeah.
You're so good at explaining these very complicated situations to us. So that's fantastic. Halley, do you have any questions or kind of observations or comments that you want to make?
No, it's definitely neat. So I'm definitely learning a lot too. I mean, I knew about the IVF treatment and the genetic testing there, but some of the other stuff is really cool too. Like I didn't know about the during pregnancy stuff, and it's definitely knowledge I can pass on to my group because it is a topic that comes up often because people get genetic testing through all stages and ages of their life.
Yeah.
So I've definitely met women who haven't started their families yet or are in the process or have one kid and are thinking about having more. So it's definitely good information to pass on. I think it's just, everything's just so, like each day you learn something new and it's really neat. And even since the time I started with my genetic testing, so much has changed. So when I found out, I believe I had my genetic mutation, I had gotten a life insurance policy prior to that testing. The laws weren't in place then. I forget what the bill that was passed that stopped discrimination based on genetic mutations for insurance policies.
Yeah.
Yeah, it's called the Genetic Non-Discrimination Act. And it's recent. I would say, I think 2017 maybe, where it went through the Supreme Court. So there was a point, I think, Halley, when we were talking about your testing, and it was something we brought up always when someone was considering testing was, people had concerns about insurance. They could look into that before having testing done because there was no legislation in Canada. And then even once it got passed, there was some pushback in terms of how that would be enforced. So we were still a little bit wishy-washy about it, but it's since been held up in the Supreme Court. And so we can be a little bit more concrete about that now, which is good for people.
Yeah, definitely. And then another big thing was too that the guidelines have actually changed for genetic testing since we first met and started this process too. So I find that, I think I only learned about this in the last few weeks, but I think that's such a win for people because at least in my case, genetic testing has been very helpful, and it can continue being very helpful for people just in awareness and just having options in general.
Mm-hmm. So awareness, right? This is something that we're trying to create, for example, with this podcast, but I imagine that you both must feel that we should bring even more awareness to the benefits of genetic testing. And so what is it that's being done out there to increase awareness?
I mean, that's a good question. I don't know, Halley, if you wanted to touch on that first.
No, maybe I think you can probably definitely pass on information because I still think it's not a lot of people know about it. I think when you bring up the gene, the easiest way to explain to anyone still is that thing that Angelina Jolie has.
Yeah.
So I find that many people still don't know about it, don't know what their options are for testing, and the only time they've ever heard about it was when Angelina, and that's just kind of, and that's not necessarily as relevant anymore, but it's that was something she made years and years ago, that she came out that she has this mutation. I believe she also lost her mother to ovarian cancer. But yes, but when you talk about having a gene mutation, you usually have to bring up Angelina Jolie, and that's how people know about it.
Just, like even now I get goosebumps thinking about the effect that she had by writing those pieces in the New York Times. Like that was huge, really huge. I mean, what a contribution she made to preventing cancers in many women. Like that was major. I'm now a huge fan of hers. And I probably haven't seen 5% of her movies, but she had the courage and the interest to write those editorials really moves me.
Yeah, and then it prompted like the number of people contacting us after that was published in terms of, interviews for different media outlets was insane. And so it just helped, like people who didn't read the article themselves eventually got information elsewhere because there was all of this other reporting afterwards. And we definitely saw a spike in interest and referrals to genetics following that. So that's for sure been helpful, just to help people talk about it, right? Take the taboo away from it, especially when she was talking about having her surgeries. And I think a lot more people were considering some of these preventive surgeries after that as well.
Mhm. All right, guys. Well, if you don't have any further comments that you'd like to make, I'd like to just wrap up by summarizing that genetic testing is something that definitely is important in this context of ovarian cancer and other cancers, that there are resources available through your health centers to get the testing done, as well as the counseling, which I think is really, really important for anyone considering this step. And that should you be found to be positive for one of these mutations, that there are lots of options to help decrease the risk of developing a cancer, but also to help determine if you would benefit from specific treatments like the targeted chemotherapies that are available right now. And we can't leave the podcast without acknowledging that this is, I think it's a really difficult topic for many people. It's like, some people I think can suffer from some guilt when they've been found to be positive. It can be difficult to talk about this with family members, but there's also supports in place to help you manage these kinds of feelings if necessary. And Jeanna McCuaig, Dr. Jeanna McCuaig is one of those people that is available for us, at least in the Toronto area. And folks like Halley Sauve, who have helped share their story or help the podcast by sharing their story or her story with us. I'm so appreciative that you've taken the time today to communicate this message to our listeners. Thank you.